I am Dr. José Figueiro. I'm the director of the Division of Kidney and Pancreas Transplantation here at MedStar, Georgetown Transplant Institute. I'm a big believer on patient education. I'm a big believer about discussing with the patient, explain to them about what they're going to be, what they're going to go through, what are the benefits, what are the bumps, because nothing's perfect in life. And once you are able to do that, it's very interesting because you feel like you and your patient have a connection, a bond, that this is a mutual project. We both are engaged in the same project, which at the end of the day is to promote him quality and, as I said, quantity of life. So my philosophy is really to become the patient partner and to educate the patient and to help them to obtain their goals, which is to have health and live better and more. I think MedStar Georgetown Transplant Institute is a unique place. This is a very mature center that has been a transplant institute for 2 decades, I would say, led by Dr. Fishbein, which has this vision of setting up this outstanding transplant center. But that wouldn't be possible if we didn't have a hospital network like MedStar with the commitment to invest in transplantation, to support the transplant doctors, the transplant nurses, the transplant system. It's a huge commitment. So I feel very blessed that I have the opportunity to be here. When I'm on call, I always live in a positive expectation that my phone's going to ring with a good offer. Especially in the kidney pancreas, which is, I have a passion for kidney, but my truly passion is kidney pancreas. I'll tell you why, because the change when you do kidney pancreas in a diabetic recipient, someone that has been diabetic for 25 years and then you place a pancreas and 6 hours after surgery, they don't use more insulin, they have a normal glycemia. And I have seen so many patients in my life that I see them after 5 years, 10 years, 15 years, and I see how they live well, and more important, I see the complication they did not develop diabetes because they had a functional pancreas. So when our phone rings from the coordinator, say, oh, there's something good coming in, that's what we want to hear. When we transplant a patient, we give back to the patient their quality of life. We give them back to the society to be active people, to work, to have their family, to build up a family. I have had so many patients that after kidney pancreas transplantation, after not being diabetic anymore, they got married, they were able to raise a family, they were able to find a job, they're able to have a normal life. Hemodialysis is very important. Hemodialysis is the therapeutic option that the patients have when they have a renal failure, and that's what keeps them alive. And a lot of people can live several years like that. But depending on your age, depending on your comorbidities, you can have a lot of medical issues because you're in hemodialysis. So the ideal situation is really to have a transplantation before you get to hemodialysis, because you will be metabolic-wise much better, nutritional-wise much better. You won't have additional insult to your heart, to your other organs. So that's why we're promoting more and more the living donor campaigns, because when you have the gift and the privilege that someone's going to donate a kidney for you, you can have that before going to hemodialysis. Or if you're lucky enough to be referred to a transplant center, example, to receive a kidney pancreas transplantation, and you get into the list ahead of time, it may take 1 year, it may take 2 years for you to get in hemodialysis, and you may be fortunate enough to receive organs before of that. They can search for us, transplant centers, before they get into dialysis. Sometimes the patient have the impression that the idea that, no, I need first to, and sometimes there's a misunderstanding that having renal failure is the same as being on hemodialysis. Hemodialysis is a chronic stage 5 of renal failure, which you have to have dialysis, but that's a disease that starts throughout the years. And you can stay in stage 4, which is non-dialysis status, for 2, 3, 4 years, depending on each patient. And If you're referred to a transplant center, you're going to be prepared, you're going to go into the list, and there's all this waiting time that you have waiting for a kidney transplantation. If you don't have the privilege of having a living donor, you can stay without dialysis. So it is fundamental that anyone that has less than 20% of the renal function should be referred and should be seen by a transplant team, because that team will be able to place this patient on the list and follow this patient very closely, and then transplant this patient if he has a living donor or eventually a cadaveric donor before going to dialysis, which is by far the ideal situation. Anyone with GFR below 20 can be placed on the transplant list or can receive an organ. What we usually do, if the patient still has a GFR around 20 and he has the possibility of having a living donor, we prepare the donor, we prepare the patient, and then we follow this patient very closely. When we see that this patient is getting close to a GFR, which is a glomerular filtration rate, which is a measurement of the renal function, when that gets close to 10%, then it's the time to go ahead and do the transplantation without having the risk that this patient will have to do hemodialysis or another kind of dialysis. Hemodialysis is a fantastic advance for medicine. I mean, if you look back 56 years ago, people would die with renal failure. And right now, there is a fantastic way to do it, hemodialysis, where you live your life. I mean, there's different ways to do hemodialysis. You can do through a peritoneal dialysis catheter. You can do hemodialysis, which is 3 times a week. Some people do at home every night. So there's a lot of advancement, and I think that's very important. And to tell you the truth, not all the patients that has a renal end-stage renal disease are candidates for kidney transplantation for different medical reasons. So they only remain alive because of hemodialysis. But definitely, when you look long-term results, when you compare long-term results of patients that has been 5, 10, 15 years in dialysis, and remember, those patients, they have comorbidities, they have hypertension, they have diabetes, they have the higher BMI, they're obese. So all these comorbidities, with the fact that you also hemodialysis throughout the years, that really cause to your heart, to your vessels, to other parts of your body, a damage that's been building up, and that can definitely impact on your life survival. If someone needs a pancreas and a kidney, they do not move higher in the list, but it's a different list. I always say that there is only one time on life when a diabetic patient, which is a very hard disease to take it, to have with all the complications, has some kind of advantage. The way our organ allocation system is set up is that when you're placed on the list for kidney and pancreas, when you get the offer of the pancreas, automatically the kidney will be offered to you. And there are less patients on the pancreas list, on the kidney pancreas list, and on the kidney list, because there's multiple causes of end-stage renal disease besides diabetes, and those patients, or even diabetics, not all diabetic patients they have the clinical indication for doing kidney pancreas transplantation. So the list for kidney pancreas, it's a much smaller list. So when someone receives a transplant, I wouldn't say they have restrictions. I would say that the patient needs to understand that he received a gift. He needs to take care of this gift as the most important thing in their life. So we transplant people to give them quality, to give them life, to enjoy with their families, to travel, to go back to work. But there are responsibilities. You have to take your medicines, you have to be a compliant patient, and you have to take care of yourself. If you have hypertension, diabetes, you get a kidney transplantation, you're still going to continue to be diabetic, and your hypertension may be better controlled, but still you have essential hypertension. It belongs to you. So you have to take care of what you eat. You have to be careful that you don't gain excessive weight. You have to take your medication at the proper time. You don't need to live in a bubble. That's also something that changed a lot. 30 years ago, when transplantation was really growing up in this country in the late 80s, early 90s, The immunosuppression medication were much less specific, they're much more aggressive. The patient has much more restriction about enjoying life and living life and being around. They used to be like in a bubble. Right now, you transplant someone on a kidney pancreas or a kidney, and they're back to work in 45, 60 days. They're back to travel, to get an airplane after 90 days. They may eventually use a mask because of the time that we're living right now. But there's no restrictions, but I would say there are responsibilities. You have a responsibility to take your medicines, to control, to have a healthy diet. You don't need to live with restrictions, absolute restrictions, but you have to understand that you have to keep an eye on your diet, keep an eye on your weight, check your blood pressure, go to your doctor, your transplant doctor, your primary care physician at the right time, and take good care of that gift, because the better you do it, the longer it's going to stay this organ functioning better. I think the kidney registry and the exchange program is a fantastic option that was built up in the recent years. I would say that it's the maturity of the donor system. When we look back, when we start doing donors, living donors, remember the first living donor kidney was done in December 23rd, 1954 at Boston. So two twins, one donate to the other. If we look back, we're talking about 70 years. And then when you look back how much we advanced in understanding the donor risk, donor profile, it has been fantastic. So reached to now that situation about the kidney registry and the exchange program. Because unfortunately, you may want to donate to someone you love, to your sibling, to your spouse, to your daughter, to your son, but for medical reasons, for immunological reasons, for blood type differences, 20 years ago, this was not possible. And now, the system is so mature from the technology standpoint in order to match, and the system is so intelligent because if you have a young donor and you're going to go through an exchange program, you're going to go through the registry program, and you are offering to the system a young donor, you're not going to get another donor 6 weeks later or 8 weeks later of 30 years older. So the system will match about the size, the age, and interesting enough, that's another fantastic thing. Sometimes, we're just discussing here, the patient's not on dialysis, he still has a residual function of his kidney that he still can live 1 year, 1 year and a half. So why I'm going to place his kidney ahead of time? I want to place it before dialysis, always. But I don't need to place while you still have a residual function. But I have a donor that for different reasons going to start a new job, or a donor that wants to be a mother 1 year from now, or she's going to have young kids. So for different reasons, her life logistics won't be suitable for her to become a donor in 1 year, 2 years from now. So then the registry program and all this pair allows you that, okay, I have a donor, my donor is suitable to donate right now. I still can wait 6 months to donate to receive that kidney. So fine, we're going to proceed with the donation. That kidney will be used, will be transplanted in another recipient, and you have a voucher. And you have a voucher. When it gets your time to receive the kidney, the register will match everything and will give it back to you, the kidney, similar to the one you donate to the system. So I think this is like the masterpiece of the system. The system became so refined with so many possibilities that and more important, there's the confidence. The system is so mature now, and there's so many confidence, and there's such a good regulation that you know that, because some people think, oh, I'm going to give my bonus ahead of time. Am I going to receive my kidney 1 year? You will receive your kidney 1 year later, because the system is so good on doing that. So I think this is a fantastic refinement of the donor system. We need to take care of the donor like the king and the queen of the process. Think about it, someone in the cadaveric donation is beautiful as a living donation, but someone in life will donate a kidney, part of the liver, to another person or to the system. Some people come altruistically and doesn't have necessarily someone that's going to receive a kidney. They said, I just want to donate a kidney. I just think there's so many people that need it that I want to do a good thing, which that's the beauty of the society. I want to do something good for someone. It doesn't mean I'm going to give anything back. So I think that the systems establish more and more, I'm not going to use the word compensation, but assurance and confidence that you are protected in that network, and that network will take care of you because you're being so nice and giving and having such an altruistic attitude. So my message to someone that I have the opportunity to talk about and to discuss and educate about their need of having a kidney and a pancreas transplantation is a message of hope. Of hope. I think that we live in fantastic times on the transplantation. Unfortunately, I always say in life, there's two ways for you to see the situation. The half of the glass that's full, the half that's empty. The half empty, that unfortunately we don't have enough organs for the amount of people that need a kidney, that need a liver. It's still, unfortunately, people die waiting for a liver, for a heart, for a lung. But on the other hand, if you look at the half that's already full, we advanced so much in the last 20 years regarding the increase of the number of the donors, the increase of the number of transplantation in the United States. If you look at the graphics, the numbers are going up every year consistently. It's because also, remember, on the kidney side, the major cause for end-stage renal disease is hypertension and diabetes, which are two diseases from the modern society. So we're not being able to catch up that. But I think that considering the donors that we're able to use today, the advance of the immune suppression medicines and the protocols, the advance in the quality of life, because as I said, the patients that receive a kidney pancreas, they go back to have a normal life, to work, to raise their family, to enjoy their life with their beloved ones. And the lifespan of the organs, when we start transplanting 20, 25, 30 years ago, the kidneys and the pancreas, they used to last 3-5 years because we didn't understand all the mechanisms of chronic rejection, of the fibrosis of the organs. Now we understand much more. Now we have so many options for the new immune suppression medication. I always say that we doctors, our job is to help the patients to understand their needs and expose to them what are their therapeutic options. And once they understand that, we're going to find the solution. And definitely having a transplantation, getting the possibility of having an organ transplant and receiving an organ is becoming more and more a realistic thing in a lot of patients' life. From the donor standpoint and from the recipient standpoint, a lot of clinical barriers, a lot of previous contraindications from the recipient standpoint, heart disease, coronary artery disease, peripheral vascular disease, other things, even weight. We used to be much more restricted about weight of the recipient than we are right now. So we're living a fantastic time. Then more and more we're expanding all this pool of donor and recipients. The future of transplantation is something that I wish I know all the answers and all the possibilities, because there's so many that it's even hard to say. I mean, as any possibility in life, the future has to be in something that we can replicate, and we can make that exponentially offered to all the societies. If you have specific procedures that will come up with the future, they cannot be widespreadly used, then that procedure really is not going to make a difference. So I think that we're advancing more and more for the xenotransplantation. There has been a lot of development, a lot of investment, a lot of research on using organs from pigs. And why pigs? Because anatomically they are the one that looks more similar to us human beings internally, so the disposition of the vessels, the size of the organs. So I think this is something that's going to happen very, very short term. I think that other technologies about artificial organs is going to become more and more available. And to tell you the truth, we still have a lot of work to do on what we have right now, in the sense about preserving better the organs that we are recovering. I think right now, nowadays in transplantation, the biggest advance is really on organ preservation. That is happening right now. So livers that were not used before, now will be able to recover those livers, place in a machine, a perfusion machine, and observe those organs for 12, 24 hours to see how they're doing, because they are perfused with blood, with human blood. So we reproduce a very real situation in the machine that will be to make sure that this is a good organ. The same way the kidneys that we're using, we're preserving, we can understand much better about the quality of the organ than we used to do it 20 years ago. So the future now is really on organ preservation, and the near future is going to be on xenotransplantation and eventually other options of artificial organs, artificial kidneys, artificial hearts, artificial lungs, that I think that with all this biotechnology investment and brilliant minds that are working on that, it's going to be very, very close to us. I think that transplantation is so fascinating because things move so fast. When I look back, when I did my fellowship 26 years ago at the University of Miami Jackson Memorial Hospital, and I look back what I do right now, I said, oh my God, I mean, it's another practice, for the better, of course, and for the good. And I think that when I look back in 50, 20 years from now, what I was doing right now, I said, oh my God, I can't believe I was doing that. There's so many new things that I'm doing right now that look so unimaginable in their reality right now. So it's fantastic. I think there's really great things to come overall. So what gets me up in the morning is really the possibility of doing transplantation, helping people around. I think that, as I said, what fascinates me in transplantation is the amount of links that you have in the chain, and to make sure that everything's really going to work and it's not going to fall apart, because if one of the links falls apart, the whole process is gone. Unfortunately, when we have organ donation, there is always a family that's going through a very hard time in losing a beloved one, and I try always to tell the patients that how big is the gift they're getting. I mean, this is such a big thing that someone, unfortunately, has to leave us. A family has to go through a major suffering for them to receive a liver, a kidney, a pancreas, an intestine, a heart, a lung. So I think that it's really fascinating to wake up and to go to work in a place like here, which is such a mature transplant center that has such a consistent story. There's such an involvement from the hospital, from the nurses, from the coordinators, from everybody. Everybody here, since the person at the door to the person in the ward helping us, everybody. It's so fascinating that the ones that work in transplantation, they feel, nobody complains because they're here at 3 a.m. They feel blessed. They feel they have an opportunity to be living that moment. Not that we do something, it's more important, less important than other medical specialties, but I have to say that everybody who works in transplantation has an intrinsic passion for what they're doing. And that's the beauty of it. Everybody that works here, they could be doing anything else in the medical field, but they have this internal driven like I have, that this is our mission here. And I see as a mission that has to be accomplished every day, and have to be every day a little farther than the day before. And I always say to infinity and beyond. That's the idea, correct? My philosophy is to try to communicate well with the patient, to try to have the patient understand what he's going through, have the patient understand that he's getting transplant, that this is a project. This is a project which, at the end of the day, he's going to be the major beneficiary of that project. We're here to help him. We're an instrument. Myself, the coordinator, the nurses, the administration, the hospital administration, we're an instrument to provide the patient care. So I think that once the patient understands that, once the patients internalize that feeling that there's so many people involved to his care, I think that those are the patients that do well. I even say that there is like a spiritual thing that the patients, when they have this positive attitude, okay, now I got it, now I know what we're doing, now I know where we're going to get it. Those are the ones that, they're bumps, there are always bumps, there's always problems, but those are the ones that really do well. So my philosophy is really to become the patient partner and to educate the patient and to help them to obtain their goals, which is to have health and live better and more. I think MedStar Georgetown Transplant Institute is a unique place for different reasons. It's like this kind of things that you have a combination of things, cosmic combination, that everything is in the right time and the right place. And this is where you have different outcomes and different results. So this is a very mature center that has been a Transplant Institute for 2 decades, I would say, led by Dr. Fishbein, which has this vision of setting up this outstanding transplant center. But that wouldn't be possible if we didn't have a hospital network like MedStar with the commitment to invest in transplantation, to support the transplant doctors, the transplant nurses, the transplant system. It's a huge commitment. So I feel very blessed that I have the opportunity to be here. So my vision for the division of kidney and pancreas is really to become a very high volume center with exceptional results. I'm not looking only for numbers, I'm looking for quality. And I think we're going to have both. We're going to be able to develop, to do as many transplants as possible. We are very committed in order to implement and to improve our relationship with all the organ procurement organizations. I want them to see us as a center that's always trying to transplant an organ. Of course, analyzing the quality of the organ, but always willing. It doesn't matter if it's a Friday, doesn't matter if it's a Saturday, doesn't matter if it's a Sunday. We have a team, and as a team we're going to work together. Some people will rest, some people will work. So I want really, we are located in the heart of the country, in a highly densely populated area with a lot of patients' needs. So we have potentially a lot of recipients, and we are potentially in an area that we can receive a lot of offers. So I want to be seen, I want the center to be seen, I want the division of kidney and pancreas to be seen as the place where people will find their need, where they're going to be taken care with respect, taken care properly, timely, and they're going to have the transplant as soon as possible. We don't control the nation, but we do all the best to expedite that, and more important, with quality. So not only volume, I always say that there's probably no other medical activity in the United States that it is as regulated as transplantation. We're regulated by every piece of the government system, and so we have to perform better. We have to perform well. But I don't want to perform as the other centers in the average. I want to perform better than everybody, more and better. That's the idea.